Good afternoon. I'm James Downey. I'm the CEO of the Independent Hospital Pricing Authority, and it's my pleasure to welcome you to this second session of the Q&A webinar series. Before we get going, I want to start the session by acknowledging the traditional custodians of the many lands around Australia on which we're all meeting today. For me, it's the Gadigal people here in the Eora Nation in Sydney, and I recognise their continuing connection to land, water and culture, and respect elders today and those who walk in spirit. With each of these sessions that we've been running, we are trying to delve into the underlying themes that underpin activity-based funding. And this afternoon's session is focused on the safety and quality measures that we introduced into the national pricing model in 2017 as a result of the first addendum to the National Health Reform Agreement. We've worked on this over a number of years, very closely with the Australian Commission on Safety and Quality in Healthcare, and we're very lucky today to have two of the key people who worked on that with us here on the webinar. Today really is a chance with this Q&A format for you to not just attend and listen, but also get involved and ask questions directly to our experts, both from the Commission and from IHACPA, into the detail of the safety and quality measures, particularly around the HACs. Of course, there's three measures. There's the sentinel events, which were implemented in 2017 and have a zero payment where a sentinel event occurs. The hospital-acquired complications, or HACs, as we affectionately know them, that were implemented in 2018, and of course now the avoidable hospital readmissions that were implemented in 1 July this year. There's a lot more background on our program of work in the introductory presentation to the webinar that's on YouTube. And if you haven't had a chance to watch it yet, I'd really encourage you to. And there'll be a recording of this session added to YouTube as well at the end of the session. I'd really like to thank everybody who's made the time to join us today. I know the health system is incredibly busy at the moment, busier than normal, but thank you very much for making the time to join us. And we had almost 500 people register for the webinar, so that's great feedback and encourages us to keep on running these. Today, the moderator for our session is Dr. Trent Yeens, who will be directing your questions to the panel and also asking some of his own. Trent's been with us as a senior data scientist since we were established in 2012, and in fact was on board prior to IHACPA's creation, and was responsible for building the very first national pricing model back in 2012. But he's also worked on a lot of other things, including our pricing models and classification systems. So you're in very good hands, and I hope you enjoy today's session, and I'll hand over to you, Trent.
Thank you, James. Good afternoon and welcome to the second instalment of the Independent Hospital Pricing Authority live Q&A webinar series. Today's session is held in collaboration with the Australian Commission on Safety and Quality in Healthcare. The discussion will focus on supporting safety and quality in the provision of patient care through reforms introduced in our National Public Hospital Activity-Based Funding System, or ABF as it's known for short. If you didn't catch the introductory presentation available on IHACPA's YouTube channel, it covers three key areas of safety and quality reform, ABF reform, namely sentinel events, hospital-acquired complications, or HACs, and avoidable hospital readmissions. You can also find fact sheets related to each of these three areas on the session handouts available for download in your browser window. So the purpose of today's session is to provide you, the audience, with the opportunity to engage directly with our panelists who share an extensive knowledge on how the adjustments for sentinel events, HACs, and avoidable readmissions are defined, calculated, and applied. Minutes to take your questions, which I encourage you to post via the Q&A widget on the right-hand side of your browser window. You can also upvote other audience questions that are of interest to you. Let me now introduce our four panelists, two of which are senior leaders at the Australian Commission on Safety and Quality in Healthcare. And we also have two of our own senior leaders here at IHACPA. To begin with, we have Siraj Razakula-Singham, Manager of Data Analytics at the Commission. Siraj has extensive experience in developing, validating and reporting on health system performance measures, specifically those relating to patient safety and quality. Next, we have Associate Professor Amanda Walker, Specialist in Palliative Medicine in the Southern Highlands of New South Wales and Senior Clinical Director at the Commission. Amanda's work at the Commission has primarily focused on the development of clinical standards, resources to support clinicians and managers addressing hospital-acquired complications, and supporting clinicians to provide comprehensive care. Our next panelist is Sharita Daylight, Director of Policy at IHACPA. Sharita is responsible for the management and implementation of policies and frameworks related to activity-based funding in the Australian healthcare system, which include leading the development of IHACPA's principal policy document, the Annual Pricing Framework for Australian Public Hospital Services. And finally, we have Dr. Samuel Webster, Director of Pricing at IHACPA. Sam is a mathematician that leads a team responsible for developing the pricing models that underpin IHACPA's annual National Efficient Price Determination. So welcome to our panelists. While the audience prepare to post their questions, I might kick things off. I won't necessarily direct questions to individual panel members throughout, unless it's obvious that there is a recipient for that question. So you should all feel free to respond and contribute to any of the discussion. So for my first question, each of the three areas of sentinel events, hacks, and avoidable readmissions carries its own set of criteria and thresholds as to what constitutes an identified event or contributing factor such as a risk factor. Can the panelists please provide an overview of the information and processes that support the formulation of these criteria and thresholds, and then also of any of the ongoing review and refinement processes that may occur on an ongoing basis?
Okay, look, I might start answering that one. This body of work actually started before I was even at the Australian Commission on Safety and Quality in Healthcare. And it was a process of basically a whole bunch of clinicians came together and they wanted to do some work in the space of hospital complications. And the first challenge was that they didn't have any data to understand, you know, as a clinician, am I an outlier? Are my patients having more of a particular kind of complication because of some of the care that I'm providing? Or is anyone in my team an outlier, or is my whole service an outlier? And so they decided the first step was to actually collate a list of complications they thought were worth actually exploring. And all of this body of work happened before it had anything to do with pricing and funding. It was actually really just focusing on what are the key complications we want to look at. And when they did that, they used 4 criteria to assess it. The first was preventability, and that doesn't mean 100% preventability, but we do know, for example, that delirium is about 40% preventable. Then it's about the impact on the patient, then the impact on the system, and then a slightly more broader one about clinical significance, which often related to research priorities, etc. And so in looking at those 4 issues, they examined a whole bunch of different potential complications, and they whittled it down to a list that's now 16. And they're all easily accessible online. Some of them are very common and you'll be used to using them all the time. But in looking at those, we developed the list, and then further down the track, I'll hand over to someone to talk about how it was utilised to implement safety and quality pricing implications.
Who wants to take that lead? Sam?
Yeah. So to implement that into the national pricing model, so as Amanda mentioned, so these complications, were defined through this clinical consultation process, and one of the key elements of that was the ability to identify these national data collection. So using the international classification of diseases, the Australian modification, so that's the ICD-10-AM classification, and associated interventions, etc. We're able to identify each of the complications as part of our national data collections. We also collect a lot of comprehensive unit level cost data associated with those hospital services. And so from a pricing perspective, we're able to analyze this data to understand what the impact on the cost of care is for these adverse events. And so we understood from international studies and from local studies that adverse events like the complications, etc., do have a significant impact on the cost of care. So as the Independent Hospital Pricing Authority, the one aspect we do have this control over is being able to incorporate this into the price if necessary to flow on and affect hospital funding. We were able to identify and confirm that these potentially avoidable complications do have a significant impact on the cost of care, and through that and through the analysis and data collection we have, we're able to determine be able to quantify exactly what that impact is, and also use the additional patient episode information, about various comorbidities and diagnoses and interventions and etc. in the data to identify, what's the risk of someone having one of these complications within a hospital. So through that, we developed a risk model to be able to kind of profile the risk of a patient developing a particular complication, and that then flows on to including an adjustment into the national efficient price determination. So these range from around 1% to up to around 20%, depending on the severity of the complication and the likelihood that a patient with a given set of diagnoses or characteristics is likely to develop the complication. So a very low an episode with a very low risk of developing a complication that then goes on to say have acute renal failure, onset within hospital that's unrelated to their initial purpose for admission, and gets a fairly substantial adjustment in the model. And that can vary quite a bit. For high-risk patients, there'll be a very small adjustment. And the idea is to recognise that there's always capacity to improve safety and quality measures or rates of complication, while also recognising that the degree to which these can be avoided does vary somewhat.
Okay, well, that's thanks, guys. That's got the ball rolling. We've got a few questions coming in. We've got several on HACS, so let's just dive a little into HACS. So, and in particular regarding the Charleston Index, which was calculated as defined back in the early 80s. And the question is about what, or has there been, is the current implementation of the Charleston Index as it was defined back in the early 1980s? And if so, why hasn't it been adjusted to reflect advancements in clinical treatment of, for example, HIV or AIDS?
So I'm happy to take that one. So the Charleston Index we use is from a recent publication from some Australian authors, which had updated the Charleston scoring methodology to suit the Australian context. So that was our starting point as a published piece of work for Charleston Index is a mortality score, and that had been developed and it had undergone a process already to validate its significance. Within our initial risk models that we built was based off published work from the University of Melbourne, so Anthony Scott and Jung Se-Yong, and they in their initial work had used the Charleston Index as a potential risk factor for complications. So we used that as our starting point, and it proved to be both statistically significant, and it was fairly statistically powerful in terms of being able to assess the risk of a complication occurring. We have tested like some other variations of scores in the risk models, for example, the rescore for pediatric patients to varying effects. That's where, so we still currently use the Charleston Index because it does show quite a bit of statistical power in being able to assess the risk of a patient. But we are constantly reevaluating the risk factors that we have, in particular looking at the individual chronic conditions, etc., that make up that aggregate index.
Okay, so another question on HACs. So the development of HACs did rely in part on the international evidence of the effectiveness of using such measures. What has been the impacts in Australia of implementing the HACs measure? And maybe a related question to combine, how can these sort of statistics be accessed publicly, and are they available publicly?
I'll give that one a crack, Trent.
All right.
So basically, in terms of the HACs and what's happened over time since their implementation, whether it be the development phase through to pricing overall nationally, and I'm happy to say that HAC rates are heading down now. The reason for that, there could be thousands of reasons for that, but I think the underlying reason when speaking to clinicians, and I hope Amanda can back me up as well, as when we have our clinical advisory groups, is that it brings to light and people are doing things about it to stop them from happening. I mean, at the end of the day, you don't know something's wrong until someone tells you something might be wrong. And then in terms of, what was the second part of that question, mate? It was about
publicly availability of reporting of these type of metrics.
For sure. So a lot of health services now, since the development of the HACs and going through the pricing, are now running their own almost internal data system, so they can feed this data back to clinicians to support the quality improvement that they're providing, whether it be at a ward level, clinician level, health service level. And some jurisdictions are even going further now, where so Queensland just came out with their Inform My Care website, which reports HAC rates. And I know a lot of the other jurisdictions are heading towards that. I'll let IHACPA talk about the benchmarking portal. And the Commission is working on a larger body of work around general patient safety reporting, which looks at a variety of safety and quality indicators and looking at how to report that. And one of those indicators being the HACs as well.
Thanks, Siraj. I'll take. Oh, sorry, Amanda. You go.
Oh, no, look, I was just going to quickly back Siraj up and say that one of the delightful things to see in the data is not only is the kind of mean decreasing over time, but we're also seeing that the outliers, in particular HACs, are actually significantly improving. It's not uncommon for there to be a facility with a rate that's twice as high as the next highest facility. And the lovely thing watching over time is those outliers are coming back to join the pack.
Thanks, Amanda. So I was just going to say, on behalf of, IHACPA, obviously we have the national benchmarking portal that is currently available for jurisdiction access, HAC rates. IHACPA are looking to expand that and make it publicly available. The plan is by the end of this year, so 2021, and hopefully then, obviously the general public would be able to then access and be able to review HAC rates at a jurisdictional level. So that is something that is in the works and will hopefully help to support this piece of work.
Okay, so just a more broad question. Are you considering expanding any of the 3 areas of safety and quality which are currently priced? Have you considered adding further options for pricing adjustments to improve safety and quality and low value care? Well, not improve low value care, the opposite, improve high value care.
I can jump in there again. Thanks, Trent. So obviously the 3 areas that we've covered were, as James mentioned in the introduction, were requirements for us under the original addendum. Safety and quality is an important aspect and something that, IHACPA and the Commission are always looking at and, refining models, updating and expanding our existing lists. Initially, I guess a piece of work that IHACPA is working on is undertaking or developing an evaluation framework, which will evaluate the three existing measures that we have, and I guess the outcomes of that evaluation will help to support future work in this space. But I think, you know, expanding that, again, IHACPA and the Commission and the National Funding Body are looking at, you know, avoidable or preventable hospitalizations. So again, coming up with defining that work and a list, and you know, focusing kind of on, you know, preventing hospitalizations in the first instance. So yeah, again, it is something that is ever evolving, and I think will continue to be a major piece of work for both IHACPA and the Commission.
So I might jump in there as well. So related to specifically reducing low value patient care. So there is a current program of work on value-based care and value-based funding model that IHACPA is undertaking. And I think this was explicitly stated as an area to look at under the most recent addendum to the National Health Reform Agreement. So this is like fairly, I guess, early on in the piece, but we are considering other kinds of funding mechanisms for certain kinds of care, for example, for chronic conditions, or bundled care for certain kinds of hospital services, to try and give service providers more flexibility in how that funding is allocated than is currently afforded under the existing ABF models. And one of the strong drivers behind that is trying to obviously improve patient outcomes and patient experience as well.
All right. So next question: has any education been provided to clinicians about how to document a hospital-acquired complication in the medical record for the clinical coding team at the hospital to be able to identify and code and report accordingly? There is a large burden and responsibility on the clinical coders who are expected to accurately code HACs while legitimately optimizing NWOW outcomes for their hospital.
I'll give it a crack.
So short answer is that education for not just for clinicians, but across the system around coding and documentation is very important. And it's something that we know at the Commission that the health services are doing all the time to make sure that the data they're collecting and providing is accurate and really useful. At the are they code what is documented in the clinical record, and therefore the clinicians have to be documenting on what's happened. And to support this, I know that IHACPA's put out the Write It Right app to assist clinicians in their documentation processes, but also this is, I'm reiterating, in a lot of the HACS fact sheets that the Commission's put out in terms of how important the documentation is to support quality improvement and that quality improvement process to feed data back to clinicians. So it's also about telling them, also about getting the message across that this isn't all about pricing and funding. It's about improving patient care. So what they document, how they document it is important so that data can be fed back to them and just in general clinical staff to make sure that improvements can be made where possible. Amanda, I think you may have something to say.
Yeah, look, there are some videos and various other supporting tools that can be used as well as the fact sheets at the Commission. But most of the jurisdictions I've been in contact with have bodies of work in place trying to address this, trying to ensure that particularly junior medical officers at orientation, because often they're the ones doing some of the documenting in the record, understand the consequences of how they document information. And as a senior clinician, you can also support your junior doctor by reviewing what they write and ensuring that the information, especially at the start of each rotation, that they understand the consequences of how they document clinical information in the record.
Okay, we've got quite a few technical questions coming in. Let me just dive into a couple of those. So the questioner says, in our review of the risk adjusted model for HACs, specifically the pricing and funding application, we found that over 90% of episodes fell into the low complexity pricing adjustment. And for the remaining 10%, that fell into the moderate or high complexity pricing adjustment, our review suggested it was driven strongly by ICU occurrence and only in episodes in the pre-MDC. Had IHACPA done similar analysis to this, and has that been experienced in the broader data set? Also, what is expected from the risk adjustment? So a broader question, I guess, at the end, but and so that questions are really, I assume the high complexity and moderate and low that's about the A, B, and C in the DRGs, and saying that the majority of HAC identification occurs in the moderate and low, in the low complexity, in the Bs and the C DRGs. Has that been generally the case in our experience?
I think I interpret the question slightly differently. So as part of the HAC adjustment model, the complexity group of a given the complexity of a given patient is assigned to a high, moderate, or low complexity group, which informs the adjustment.
Oh, sorry. So it wasn't DRG related. Yep.
So yeah. So I'm assuming this is about the HAC complexity groups. When we set the thresholds, so broadly the way the complexity or the risk adjustment model works is that based on the presence of certain risk factors that were determined through clinical consultation in developing our risk adjustment model, each of those risk factors has a certain amount of complexity associated with it, and then the combination of all the risk factors will define a total complexity score for a given patient episode. And then looking at that score, a lot of the early options we considered were having a continuous adjustment that might depend directly on the score, or using 10 different complexity groups, or 5, or no complexity groups. Ultimately, for the kind of optimal balance of simplicity and effectiveness of the model, we ended up with the 3 complexity groups: the low, moderate, and high. And so your score determines which complexity group you go into. Now, when those threshold cutoffs are determined to assign episodes into different complexity groups, there are requirements around that to ensure that not everyone goes into a single group. So in the question, I think you mentioned that they'd noticed that over 90% of episodes went to low complexity. So that isn't our experience on the national data set. It's more evenly distributed than that. But it is something we are evaluating the models as we go, and those complexity group definitions are refined each year depending on the latest data collection that we have. So we evaluate the complexity scores over 3 years of data to try and make sure that those thresholds we're seeing are suitably placed. And the purpose of the risk adjustment model, I guess, which was the last part of that question, is to accurately account for the underlying complexity of particular admissions. So highly complex patients will have a higher probability of having a complication occur within hospital, and it's about recognizing that as a result of them having a complication is much reduced due to the fact that they're extremely high complexity to begin with.
Okay, so the next question is on the actual implementation, I guess, of these pricing adjustments and the way they actually play out at an LHN sort of level. And in particular, it appears to the questioner that there seems to be a disconnect between the language used by IHACPA and the reality of how the penalties are actually take effect at the LHN or LHD or hospital level. On the one hand, the webinar and the fact sheet state that funding won't be received for, say, sentinel events or reduced funding or NWEL for and hence funding for HACs and avoidable readmissions. But in reality, the questioner says there doesn't seem to be a direct correlation between the event and a budget adjustment at the moment. There's a notion of it affects the actual growth in funding, but then the questioner says that the states allocate budgets to LHNs and then the LHN allocates out accordingly. So the question is, do you think this connection will be more visible in the future, or is it possible that the growth will overshadow the penalties and no reductions will be felt in the areas where the events are occurring?
So this is a pretty interesting question, and I'm happy to take it. If anyone wants to jump in, feel free. So there's the way, I guess this is just tied to how the public hospital funding system works in Australia. Due to our government structure, the Commonwealth under the NHRA, had agreed to fund a 45% of growth in the efficient price of public hospital services, and the state funds the remaining component out of the state budgets. And so all of the safety and quality adjustments that we do build into the national efficient price determinations are adjustments to the national pricing model. So this affects funding allocations from the Commonwealth side. So this is the Commonwealth funding in the national model. How much of that funding goes to states at the end of the day, or to LHNs when the National Health Funding Body finalises their allocations. So the majority of funding, so I think it's normally around 60% of the total funding for a hospital or an LHN budget comes from the state funding model, and the state funding models can vary from the national. So some jurisdictions don't implement the safety and quality adjustments at all in their local funding models. Some implement ours exactly as they're stated in the national efficient price determinations, and some jurisdictions will have somewhere in between, so might include adjustments for some of the safety and quality measures, but not all of them. And this is, a point which comes up quite often, especially talking to LHNs or to hospitals, in that the message they get is different from their state health department compared to the fact sheets that IHACPA publishes. But I guess that is something that's fairly tough to manage, and the reason we're doing webinars like this to try and make that as clear as possible. So do I think this connection will be more visible in the future? I think it will be, as as data becomes more accessible by end users, and it won't necessarily be that the growth funding model overshadow any penalties. I think as a result of how the national funding works, so because of this growth funding model, which we're bound to at the moment under the agreements, and how the national funding model is just has been determined to work, it does only affect growth. So, and it does overshadow the effect of HACs or any of the safety and quality adjustments. I wouldn't say it completely overshadows it, but it does dampen it quite a bit. It has this effect where only pricing adjustments are felt or noticed where there's been a change in rate. So if your complication rate increases dramatically between years, that's where the penalty is really going to kick in, because it only really affects the growth portion. Whereas if your complication rate decreases significantly between years, you actually end up getting a positive impact on the Commonwealth funding contribution.
So you're saying that it doesn't affect the district. So does these safety and quality adjustments affect the NWOW recorded at the LHN level? Is that correct?
Yeah.
They would create a reduction in the NWOW at the LHN level?
So it creates a reduction in the NWOW at the LHN level. That's right. And so that would then lead to that LHN receiving a reduced proportion of the state's funding allocation from the Commonwealth. So in that sense, a reduction on account of safety and quality adjustments, a downward reduction in the NWOW for an LHN would reduce that LHN's proportional share of the state's funding from the Commonwealth, and hence there would be that immediate effect of these HACs. And there is also that growth aspect, which is a state level aspect to the There is, and I think a key part of that is that when you refer to the overall funding pool that gets allocated between LHNs, the size of that funding pool is determined based on the growth. So if HAC rates, for example, decrease markedly between years, the size of the pool would actually be slightly higher than if HAC rates had remained constant, for example. So the pool would be slightly bigger, and the allocation of funds to LHNs at the end of the day is the HAC adjustment also affects that, obviously. The funding formulas are really complicated to understand and explain, but hopefully that gives people a reasonable idea.
Okay, so next question. Has IHACPA or the Commission done any work to investigate whether penalising HACs impacts on the accurate documentation of HACs? In other words, what is captured in clinical coding of diagnoses?
Yeah, all right, I'll give this a go. So in its entirety, at the end of the day, the Commission does a lot of work with local health services, clinicians, administrators and whatnot to sort of get the point across that the HACs are about quality improvement. And if you're going to change the way you code and document stuff based on HACs occurring or not, then there's a different issue that needs to be looked at. And gladly, and I think Amanda will back me up, during the whole HACs curation process and all the clinical process we've had, the clinicians are all for this in terms of documenting accurately to capture this data and for there to be able to fed back to them to see where improvements can be made. So on its entirety, we don't think that that's necessarily happening in terms of clinicians seeing a pressure injury and then not documenting it and therefore not getting coded. Now, when I say we, the Commission does monitor the data ongoingly, as would IHACPA, in terms of what these HAC rates are doing and if there's sudden jumps or jerks and there's anything in the data that looks a bit weird. But all the feedback and all the consultation that we've had, we don't see this as an outrageous issue. Amanda?
Yeah, in the discussions with the clinical panels, one of the things that keeps being brought up is the fact that you're still better off to declare the HAC, because even if there is a pricing signal, it won't be more than the ABF funding that you get for that diagnosis. And so it would actually not be in your best interest to not document the HAC, if that makes sense. And so when people have been nervous, everybody has, like the clinicians have all agreed that it is important to document the HAC. You will still be better off for documenting it.
Yeah, and just echoing Amanda's comments as well. So including those HAC diagnoses often contribute to the complexity of the patient. And so that means accurately documenting the hospital-acquired complication or the related diagnosis often will increase the complexity of the episode, which actually results in a higher funding bracket, like a more complex DRG, which gives you a kind of higher starting base before any penalties are applied. And further to that as well, we have noticed that the reporting of the condition onset flag, so this is a crucial data element in recording hospital-acquired complications, with particular diagnosis was recorded as present on admission or not. And that we've actually noticed the quality of the condition onset flag reporting has improved markedly since it was introduced for the 1819 determination.
Okay, so you've got me thinking about data quality, right? And if you will indulge me, this is one of my questions. So, so just thinking end to end in terms of the collection and flow and feedback information from the clinical information to the identification and the classification of safety and quality related events, to the pricing adjustments and the funding effects, and any feedback loops that occur within that cycle, such as national or state-based reporting or other locally defined information-based clinical support mechanisms. So in that broad context of information, to me, these reforms and activity-based funding reforms more generally lead to improvements in the quality of information collected and communicated. And this in itself can support in many ways improvements to the delivery of high quality care, like has that capacity, has that potential to support improvements. Can the panel members reflect on what aspects of this information flow and feedback, specifically related to the introduction of these reforms in safety and quality in ABF, they believe are of particular importance in supporting improvements in the quality and value of care?
So I might start by just flagging that original question I asked, as a clinician, how do I know if I'm an outlier? I think the beauty of the HACS data is that it's based on admin data, and I don't have to go to any blood, sweat or tears to collect extra information to get this. It's pulled out of the clinical record and I don't have to go to any extra work. And so the thing that I really like about the HACS data is, without much trouble on my part, I can find out, am I an outlier? And different jurisdictions are sharing that information in different ways. And I think one of the crucial things is making sure that that information is available and clear and transparent to the clinician. And ideally, not just how am I doing, but who are the people who are doing really well, so that I can actually find out what they're doing differently to me and I can model my practice off them. The commission has talked about some targets, and we don't expect people to actually become perfect and not have any hospital-acquired complications. But what we want to do is see the whole country move to the level of the better performing facilities, ideally the top 25%, so that we learn from our colleagues who are doing really well. What processes and policies have they implemented? What are the clinical practice components that they reliably perform so that patients get better outcomes? And I think there's an opportunity for us all to share who's doing really well and what are they doing, and support that kind of implementation of best practice so that everybody gets to a better level. Does that make sense?
Oh, for sure. Yeah.
Yeah, and I'll in terms of clinicians and the ease of getting, when the commission went through the HACS development process and the curation process, a lot of the clinicians we spoke to just didn't know about this data, like this admin data. They realized that they document all this stuff on the medical record, it gets coded, but then after that goes into the ether. They had no idea that this sort of data is captured and could be fed back. So following on from our curation process of the HACS and even the readmissions, a lot of clinicians started coming back to us asking, who do I talk to about getting this data? How do I get access to it? How do I set up a process in my health service to feed this back? So that's been one of the most encouraging things I've had over the commission over the last few years of looking at the HACS list and running the data, is sort of being able to explain to work with clinicians and like talk to their to the information managers about how you can set processes up to feed this data back in a timely manner. And just off the back of my hand, I can think of a fair few health services that I've spoken to over the last 12, 18 months where they're setting up programs, specific programs for reducing HACS and to improve how they feed this data back to clinicians. So it's not just a spreadsheet they send out at the end of the year or at the end of the quarter, where it's more of an interactive dashboard that the clinicians can go onto on a weekly or fortnightly basis to see how they're going for the past week, past fortnight, and to see how their trends are going, and whether it be at the clinician level, the ward level, the facility level. All different health services are at different stages with this, but it's just really encouraging to see this data feedback really happening. At the end of the day, the commission would like all this data collected and then provided back to where it's going to make the biggest difference, which is back to the clinician, which is back to frontline health staff.
And I'd add even more that ideally what we'd see is this data being routinely reported and discussed in clinical meetings. So for example, morbidity and mortality meetings, when your team are gathering and they're actually looking at their outcomes and understanding, oh, we have an issue with this, and our next focus and quality improvement is going to be on this clinical problem because we've identified from the HACS data that we could do better.
Add to that a little bit as well. So off the back of something Amanda said earlier about, there's not an expectation that HACS will suddenly be eliminated, but it's really about bringing those outliers down towards, with the rest of the pack. And I think the design of the funding model really supports that as well, and the pricing adjustment, in that it's not anyone with a complication gets this big penalty, but it's really about that change in complication rate. So we're not, expecting any, extreme change from a lot of HACS to no HACS between years and suddenly everything's fine, but it's about that continual improvement process too, and that improvement in the rate of HACs, so reduction in the number of complications or readmissions or sentinel events. It applies to all of them. That reduction in the number really, the design of the funding model really incentivizes that.
Okay, so I've got another question. I've got a question on value-based care. So when a hospital chooses to adopt a new technology that supports value-based care, how does IHACPA and from a pricing and funding perspective, and the Commission in various other ways in their sort of realm of work as well, how do you support these particular decisions? So how is it? Yeah, sorry. So how is the actual how are these sort of what would be regarded as positive choices towards value-based care decisions? How are the choices supported by the work that IHACPA does and the Commission?
I can jump in there, Trent. So as Sam mentioned earlier, IHACPA is looking to expand or look at other options for funding and pricing approaches, and as part of that is looking at capitation models or bundled payments, and with the focus obviously of improving safety and quality, but also giving jurisdictions, LHNs an opportunity to innovate, and we recognise that obviously activity-based funding is great for a lot of patients and a lot of, but we know also that there's specific cohorts of patients, chronic disease patients that it's not necessarily amenable to. So IHACPA as an organisation are looking to expand and look at alternate kind of funding approaches. I think that will also, in terms of the quality, the safety and quality space, it is something that as an organisation we note that we've had ABF in place since back in 2011, and then we note that things are moving. Jurisdictions, LHNs, hospitals are trying to innovate in other ways, and that's something that as an organisation we're wanting to recognise and I guess investigate further as well.
I'll jump on to the end of Schrader's response as well. So in relation to that, so we do have, not directly related to value-based care, but we do have a new technology evaluation framework where we try and incorporate new technologies that are being used into our classifications and into the price where it makes sense. And on the value-based side, I guess there are, so through our process of determining the general list of in-scope hospital services each year, there is scope and examples where innovative programs have been added to the general list of in-scope services, so that they've been funded, for example, under block grants to enable that flexibility of funding allocation instead of directly through ABF. But yeah, it is a space we're really putting a lot of work into at the moment.
Okay, so on these sort of innovative funding models and so forth, there's a question saying, I mean, just to tie that off, and so how can state health departments and public hospitals put forward proposals to access innovative funding models such as bundled payments? And is there a framework that lists out the steps and criteria to put forward in such proposals that is available in the public domain?
Yeah, I can take that one. So as part of our recent pricing framework consultation paper, we sought feedback on potential innovative funding models that jurisdictions are looking to trial. And we got some extensive feedback as part of that. IHACPA is currently developing a framework which will outline some criteria and whatnot for jurisdictions to be able to trial innovative funding models or alternate funding models as part of a trial, a pilot basis. that will, again, it's in the early stages, but that will give, jurisdictions an opportunity to potentially shadow price or trial, some alternate or innovative funding models as part of that process. And I guess, we're still in the early stages, but we are in the process of, as Sam mentioned, it is something that we are investing a lot of time in at the moment, and recognise that it's something that jurisdictions are very interested in. But yeah, we are in the process of developing a framework that hopefully will be in the public domain in the not too near future.
Cool. So, and just coming back to a previous response around the publication of hack rates via IHACPA's benchmarking portal, access to the general public. The question says timeframes would be useful.
So we do have, again, in our pricing framework consultation paper, we have said in a number of different forums that we're looking to make the benchmarking portal publicly by the end of this year. Obviously, we're just working with jurisdictions around ensuring that there's safeguards in place, that there's appropriate education and materials available to ensure that the data is used in the right ways. So I'm saying the end of 2020 is our plan, and we're on track to achieve that. So
yeah, and that'll provide the foundation for that publicly accessible information, but I think that it'll roll out in terms of the range of metrics that it'll be reporting on and so forth. So over time. So on to avoidable readmissions. So regarding avoidable hospital readmissions, can we talk about how a readmission is determined to be clinically related to the index admission?
Well, this was a huge body of work. Oh, Suraj, do you want to speak to it? Or?
No, Amanda, you're good. You're good.
Come on, guys, don't fight.
So it was a really large body of work, and we pulled together clinical panels that were appropriate to the different conditions. And we started looking at the original HACS list. And then we also looked at what were the causes of frequent readmissions to see, was there anything that we were missing? And then we actually sat down and considered them from the same kind of perspective of those 4 issues: preventability, impact on patient, impact on system, and clinical significance. And then we looked at when the readmissions were most often occurring. So what was the time frame and the frequency of admissions in the period of time after hospital? And we also explored, was there any information in the literature about attribution? And we also looked at the pathophysiology of the condition. So, for example, some of them have very long readmission periods. So, for example, venous thromboembolism, there's really clear data internationally and in Australia that your likelihood of having a VTE is significantly increased for up to 3 months following hospital admission. And that's why that time frame is 90 days, where there are other conditions where it's clearly a very short time frame and it's only within the first 2 days. When we looked at readmission, some of it was also about appropriate discharge planning may have prevented this representation. So, for example, if patients have, complex conditions, and whether better discharge planning would have improved the outcomes for them. So that was basically how we've considered it. Does that answer the question? Suraj, do you want to chip in?
No, I think you covered it pretty well. I could just add to that oh, did I just drop out? No. That basically the clinicians, when they looked at the data along nationally and their clinical experience and looked at these readmission timeframes, it really came down to the argument of, if someone with a certain condition is readmitted within this time frame, then it is more than likely related to what they were in hospital for in the first place. And that's the sort of line in the sand where that's sort of line in the sand that they had to draw.
All right. Now, Amanda, I've got this question. It's got collected a few upvotes, but I can't recall what the context was for the question. It says, Amanda's comments, I should have asked it earlier, right? Amanda's comments on reducing means and outliers. Have these results been published anywhere?
Well, we did actually do a short video presentation at the IHACPA ABF conference earlier this year. So that data is accessible online, I believe.
So the presentation would be available?
Yeah, the presentation should be available. But I'm sure if you contact Siraj, he'd be very happy to help.
Look at this data in the Commission's State of Patient Safety Report, which was released in 2019. So that data obviously is a bit older now, but there is some initial data in there. And yeah, as Amanda said, our presentation from the ABF conference this year also covered some of this as well.
So I think you might have touched on this earlier, Siraj, but so the question is, has the HAC funding model worked? So is there a quantifiable reduction? I think you talked about the quantifiable reduction, I might be wrong, on the number of HACs since the implementation of the funding adjustments.
For sure. So going back to when the HACs were first spoken about as a concept back in 2012, 2013, 2014, the original development, and then through to pricing in 2018. And now there's been a considerable drop over time. And this isn't just at the national level, at jurisdictional level. Also, when you look at health service level across all the HACs, there is that downward trend happening. And that I'm hoping is because of these conditions being brought into light with the clinicians and clinicians acting on the data and trying to do whatever they can to improve them.
All right, so this question goes to perhaps the ongoing review and refinement work that is related to HACs and so forth. So the question says, hospital clinicians often disagree with some HACs, and it's difficult to get them to agree. Have other jurisdictions have these issues? And hypoglycemia is one of the HACs that has caused this issue. Is this being reviewed? So what are the sort of standard review processes that are in place in this regard?
For sure. So for that first part of the question, yes, all clinicians across jurisdictions sometimes have issues with the HACs that are being fed back to them. And that's probably a good thing in the Commission's eyes. It's good to know that they're getting the data back and they're paying attention and looking at it and reviewing it. In terms of the review process, so there's a few channels that health services or clinicians can take. Well, one of it is obviously contacting or providing some data or some information to the Commission or to IHACPA during the consultation processes, really just highlighting what they found in their cases in terms of this was coded as a HAC, but we don't think it was, doing X, Y, or Z to see if this has an effect. So for sure. So the whole HACs process, the list is a very iterative process. So since the list was originally released in 2016, I think we went from version 1 and now up to version 3.1 with a lot of little changes based on feedback like this, whether it's come straight to the Commission or through IHACPA's consultation papers during their pricing frameworks, where health services jurisdictions or clinicians have brought forward concerns or queries, and we've had to maybe tweak things around the side, maybe add additional diagnosis codes or move some and shift the list around. So any feedback is always considered as good feedback, and it helps us improve on the list to make sure that it does remain useful and current.
And I'd add to that, just remembering that we don't expect these to be 100% preventable. And so hypoglycemia is a perfect example of where some of it may not be preventable, but definitely some of it is. And the endocrinologists are very keen that this continue as a HAC because it's an important indicator for them as well. And it helps them identify which wards in the hospital there are areas that they need to focus on in terms of education and support. Okay, so again, it's not 100%, but it definitely can be improved.
So another quick question, there's only a few minutes remaining. Aside from the national standards and monitoring performance, what practical support is being provided to states and health services from a national perspective with a similar focus on quality improvement?
So in terms of addressing the HACs, there are a series of supportive tools that are accessible on the Australian Commission website. So we've got a series of fact sheets to support the implementation of addressing the hacks. Some of them are quite extensive and in-depth tools that are to support, for example, the quality and safety manager, trying to make sure that you have governance processes to address the hacks, all the way through to simple 2-page sheets that are for clinicians about what do I need to consider when I'm trying to address this hack. So there's a series of different tools that you can access online.
All right, I think that's a wrap. Thank you for joining us this afternoon. I hope you found this session useful. The next session in the series, which is scheduled for October, will discuss classification development, by which I mean the development of health-related classification systems, such as the Australian Refined Diagnosis-Related Group Classification, or ARDIG classification, the Australian Emergency Care Classification, or AECC, the Australian Mental Health Care Classification, AMHCC, just to name a few. And I note that there are quite a few questions that are specifically related to classification systems and in the context of safety and quality. So I urge you to come along to the next session and ask them there. So these classification systems are fundamentally important to the activity-based funding system and are a key focus of IHACPA's work program. So to find out more, including upcoming sessions, topics and dates, head to our website, ipa.gov.au/events. We look forward to seeing you all at the next IHACPA event soon. See you then.
Thanks, everyone.